Hey classmates! We're here to talk acronyms with you. Specifically, we're going to try and shed some light on CMGs and CMIs and RIWs and some other three-letter concepts needed to understand Canada's approach to understanding who we provide health services to. So let's get started. Canada's healthcare system has faced challenges in recent years as a result of reduced funding and an aging population. In times of fiscal restraint, hospitals need to describe their patient population according to resource utilization and length of stay. Case mix tools are designed to address the enormous challenges faced by governments the world over. How to allocate limited resources in a fair and equitable way. A good case mix system makes clinical sense, providing meaningful clinical descriptions of individuals in a group. The application of case mix is broad. It provides the basis not only for reimbursement, but also for comparing the population within and across programs, and as a staff planning tool. In the 1980s, hospital administrators and physicians identified a need to better describe hospital output, which is also known as the hospital case mix. At the time, they were using total cases and total patient days, which were proving to be ineffective measures of output. There was some thought to use the International Classification of Disease as a measure of output. Every hospital patient in Canada is assigned an ICD code upon discharge. As this was already a widely implemented classification tool, it seemed like a good starting point. However, at the time, the latest version of the ICD included more than 10,000 codes, which made it difficult and cumbersome to use. Canada needed a more manageable classification system of hospital output, and a Canadian version of the diagnosis-related groups, or DRGs, was created, called Case Mix Groups, or CMGs. Case Mix Groups make up a tool that is used in Canadian hospitals to describe the types of patients they treat. It implies grouping inpatients according to similar characteristics, such as the most responsible diagnosis and the resources that they used while in hospital. Case mix groups are especially important for hospitals because they allow a better understanding of the relation between the medical and financial dimensions of hospital operations. In Ontario, they also affect hospital funding by allowing hospitals to monitor clinical practice and resource use. Lastly, by measuring hospital output, hospitals can be compared to one another, and benchmarking is made possible. An algorithm based on the clinical information of the patient is used to assign a patient to a case mix group. There are currently about 567 CMGs, which are divided into 25 major clinical categories, MCCs. Each MCC is based on one of the body systems, for example, the respiratory or circulatory systems, and is further classified as a medical or surgical case. The following is just a brief overview of how exactly a patient is assigned to a CMG. First, when an inpatient is discharged from the hospital, the physician writes a short report in the patient file, including information such as the diagnosis most responsible for hospitalization, other diagnoses, comorbidities, and procedures received while in hospital. Next, health records employees of the hospital will assign the appropriate codes to the description provided by the physician into the Discharge Abstract Database, or DAD. This information is sent to CIHI. Once received by CIHI, they use the Case Mix Index algorithm to group and classify patients that are clinically similar with regards to diagnosis and their group of hospital resources. It is at this point that patients are assigned to a case mix group. Therefore, patients with the same case mix group are clinically similar and use similar healthcare resources. There are several ways that the CMGs can be assigned. For example, they could be grouped in either group 517, 518, or 519, which all fall under the category of diseases and disorders of the kidney according to the figure. Consider Jessica, a 34-year-old patient who has a urinary infection and other complications. Using this information, she's categorized into the group 518. Consider Elizabeth, another patient. She is 75 years old, but she only has the urinary tract infection. However, she would still fall under group 518. These two patients therefore have similar length of stay as well as number of services utilized in the hospital. In order to understand CMIs, we must first understand what RUGs are. A Resource Utilization Group, version 3, or RUG3, is a grouping method that categorizes data from the continuing care reporting system into groups based on the clinical and resource utilization similarities of the individual assessed. So what is this structure? There are 7 RUG3 categories, and each category has a number of resource utilization groups. The categories are ordered in a clinical hierarchy from most to least resource intensive, as shown in the figure above. On to the CMI, or Case Mix Index. The CMI is a relative measure of resource use and how sick the patients really are. Each RUG3 group is associated with a CMI value, so the CMI value gives an indication average daily resource use for individuals assigned to a particular group. It is a useful tool for predicting income, summarizing patient populations, explaining the cost of treating those populations, and suggests what kind of services are most viable for the population. So why are RUG3s and CMIs important? Well, they're used to better understand characteristics and needs of resident populations. Also, RUG3 and CMI values can provide facility and system managers with research-based evidence for planning, quality improvement, and resource allocation. The CMI reveals how sick the patients are. And in other words, the higher the CMI, the more complex the patients, and the larger the number of surgeries, indicating they have used costly or complex resources. Who is the CMI important to and why? The CMI is important to hospitals, Medicare payers, the general public, and other payers for a variety of reasons. This includes aiding management in establishing financial liability, promoting efficient resource management, assessing risk, as well as the general public paying close attention to the hospital performance. Finally, what do these results mean? A CMI calculation is useful for analyzing and comparing trends. For example, if CMI is lower compared to other healthcare facilities in the area, this might indicate that patients are seeking alternative facilities. Similarly, a dip in the CMI might also demonstrate a downward trend in the surgical and treatment volumes. Let's look at an example. A patient named Tom has appendicitis, and from this information, he is categorized at a CMI stage of 1.01. Stage 1 is the lowest severity classification for illness, and it means that Tom does not have any complications with his disease. If Tom had been categorized as CMI stage 4, he would be considered in the highest severity classification, which means death. Let's move on to RIWs, or resource intensity weights. Developed by CMI, resource intensity weights represent the intensity of resource use associated with different hospitalization types, and takes into account the demographic characteristics of a patient. In other words, RIWs measure the volume and intensity of hospital clinical activities. Any change over time in the sum of RIWs signals a change in the volume of complexity of patients. As the sum of RIWs increase, so does the expected total cost of treating patients. So why is this number important? This indicator is used to assess how well an organization is utilizing its resources and can be used to influence budgeting, fund reallocation, and healthcare planning. RIWs is an important measurement for hospital cost and reimbursement, and hospitals under an activity-based funding model are paid, in part, based on outputs that RIWs measure. Examining the differences in resource utilization can allow hospitals to focus efforts to improve efficiencies. So where did RIWs come from? Canadian hospitals have been historically funded by mixed payment amounts, with adjustments for location and number of cases. Concerns regarding the fairness of this system of funding brought about the development of resource intensity weights in the 1990s. The premise was that hospitals providing comparable services had similar resource needs, and thereby should be entitled to comparable funding. So who are RIWs important to? Well, they're important to hospitals, physicians, other healthcare providers, CMI, regional health authorities, and the Minister of Health. Let's look at how RIWs are used. Case mix groups are assigned RIWs to measure the resources that are typically required for the case. CMI collects and calculates RIWs, and these measurements are used for evaluation purposes. Cost information can then be communicated to physicians and other healthcare providers who help ensure that they are aware of how the resources of the hospital are being used. One of the main advantages for using RIWs as a unit measurement is that it enhances the comparability by taking differences in the acuity, severity, and complexity of cases into consideration. Another advantage of the RIWs is that it can be used to project future hospital costs and the volume and intensity of clinical activities. This can aid hospitals in healthcare planning, budgeting, reallocating funding where appropriate, and improving the efficiency of healthcare delivery. RIWs also provide a simple, approximate approach to estimating patient and program costs. However, there are limitations. RIW as a measure of resource use cannot replace full implementation of the service recipient costing. An activity-based costing model is described in the Guidelines for Management Information Systems in Canadian healthcare facilities. Ideally, cost estimates and RIWs for the patients in each CMG should be calculated from a Canadian database of patient-specific costs. Unfortunately, such data does not yet exist. The main limitation of RIWs is the use of New York cost data in the formulas, which assumes that the relative prices, quantities, and mix of resources expended on a patient in a Canadian hospital are approximately the same as those in a New York hospital. Let's look at an example. A 74-year-old patient named Bob has influenza and is categorized with a case mix group number of 104. The complexity of potentially life-threatening conditions is also taken into account. Complexity is rated on a scale from 1 to 4, with 1 being the least complex and 4 the most complex. If we consider that Bob has a complexity level of 4, we can then use this information and derive an RIW value of 1.2. However, if Bob only has a complexity level of 1, then his RIW value becomes 0.6, as his case is less complex and less resource intensive. More funding would therefore be required in the former case.